Hello, as you all know, I'm Dr. Lawrence Yang. I'm a family doctor in Surrey, and I'm joined here today with Dr. Quynh Doan. Did I say that right? How do you actually say your name properly?
You did. It is Quynh Doan, but you know what? The doorbell just rang. Can we
Oh
just
yeah, go
pause for
ahead,
a
go get
second?
it. I'll pause it.
Okay.
Wow,
Glad you got to witness this. I just got some flowers.
it looks like someone just sent you flowers.
Yeah,
Wow,
yeah.
I I knew I was interviewing a superstar. That's what Rob Hewlick told me.
That is so funny.
I love how you planned that. I love how you sent
I know,
roses to
right as
yourself.
we started. A student,
Oh,
a
that's
student I
lovely.
had in my lab a couple years ago. Yeah.
Oh, that's so lovely. Oh, I'm
Yeah,
glad.
that's really nice. Yeah.
Is
Yes.
today a special day? Is today your birthday or something?
No, no, no. No. I guess the student is transitioning. They're applying to
Okay.
grad school, and they sent me a like a
Oh,
thank you note for
for mentoring them, for being there for
yeah,
them, and that's awesome.
yeah, yeah,
Mhm.
yeah.
So
Timing.
I actually my my father, he grew up in Saigon, and
Mm,
and at age 16 he went on a boat and he went to Taiwan and then did medical school there and stuff. But he speaks Vietnamese, and so I took some Vietnamese classes, and
that's amazing.
I if I was to really say your name, would it be something more like Wing Yong or something like that? How do you actually
Um,
say it?
so in Vietnamese, like
Mhm.
many Asian culture, as you know, when we introduce ourselves, we always introduce ourselves with our last name first,
Okay.
and then our proper name. So when I introduce myself to Vietnamese, I introduce myself as Doan
Duan,
Quỳnh Hương.
Duan Wing Hung.
Yeah,
Okay.
Quỳnh. And
Oh,
and
Quinn.
and then you've got like the northern, and then you got the southern tone. So in
Mm.
the northern part, you actually say Quỳnh, like a hard
Oh,
Quỳnh, right? Quỳnh.
yeah, yeah.
And in northern Vietnam, they tend to round everything up, and so we can win.
Win, yeah.
Win
Oh,
as in, but then they also pronounce H as win. And
yeah,
so technically speaking, if a foreigner learns the Vietnamese language, usually it's preferable that they learn from a northern speaker,
mm,
because then they learn to enunciate and pronounce every letters and consonant as they're intended to be.
mm,
And there's a duality between the North and the South before 75.
yeah,
And language is one of them as well.
yeah. If I assume that you were actually born there, born in
Mhm.
Vietnam, and how was your journey over here? Was coming to Canada, was that something that you had to navigate yourself, or were you with family, and was it very challenging?
Mm, that's a very interesting story. So I came here at 1, so I was very young.
Okay.
Um, so I practically grew up in Quebec, and I learned French as I learned to speak. Um, and my father was a musician in the North, and when the war started, he was, forced to enlist. And as they moved their way from Hanoi to Saigon, once they reached Saigon, he defected and joined the Americans in the South. And because of his background, he was an entertainer and a singer, and so he worked for the radio station with the Americans, singing, telling stories,
Wow.
hosting. And so when the Americans left in 75, I had just turned 1. And because of his connection, we were able to go. We were one of the few Vietnamese that were able to leave with the Americans as they took off. So we ended up in a refugee camp in the US near California. And after a few days, couple of weeks, we were allowed to either go out to California and make a life, or follow a program that was available in Canada to come to Quebec, learn the language, and establish yourself here. So my first stop in Canada was Chicoutimi on a farm in the middle of winter. And yeah.
Wow. So you grew up in the East Coast in some cold parts of Quebec, and did
Early on,
you
yeah.
did you end up doing your medical training out there out east?
Yes. So I grew up in Quebec, did all my schooling in French, and then did a CEGEP program, and then went into a pre-med program at McGill. And so I learned English really quickly that summer before I started between CEGEP and MedP, and then did a year of pre-med as the program allows, and then started Med 1 after that year.
And did you always know that you would do something in the pediatric realm?
Not in pediatric. In medicine, it was ingrained in me at a very young age by family and expectations that there should be someone in the family that goes into med school. And they went through everyone in the generations above me, down to my last uncle, who's 4 years older than me, and that didn't go. And so then they started looking at the grandchildren. And so it was ingrained in me that I had to get into med school. Pediatrics came during rotations. And in fact, I went to med school thinking I was going to go into geriatrics. I spent my first summer in Med 1 doing a geriatric workshop camp type thing in Toronto. And that's what I was going to do. And then first rotation ever was pediatrics. And I was sweating bullets. I just was hoping to pass the rotation, and then ended up loving it and comparing everything to it after. And then there you go, at the other end of it.
Wow. I can't believe you learned English. It sounds like you learned English in like 1 year. Is that really what happened?
Well, I did. Well, you have English as a second language the same way you learn French out here. And so, I passed through those years, and then I did an intensive summer course where I like Monday to Friday, 9 to 3, the whole summer in immersion with international students from Europe, from Asia, and that's how I spent my days that summer. And then the first year, literally elective courses. I don't know what possessed me to take microeconomics, but I had my microeconomics textbook and my English French dictionary, and I was like just going one line by line by line. And so medical school became, relatively approachable after microeconomics in English.
What an interesting text to learn English from, the microeconomics textbook.
No, that was hard.
Yeah, you must have had a very interesting conversations with people after that. What brought you to Vancouver?
So I interviewed in pediatrics for my residency in the winter of 97, like the early 98. So that was the ice storm on the east. I don't know if you remember that, but everything was frozen in ice. There were power outage. It was gorgeous, but it was very destructive. And I only made it out of that area for one interview, and that was Vancouver. And as I'm landing in Vancouver, knowing that pipes were bursting and there was no power back in my home, I landed and I looked down and I said, "What's that green thing down there?" And the passenger next door to me goes, "That's grass." I'm like, sold.
What a great story. That's grass.
That's grass in February. I'm like, done.
Now you're doing a lot of research work now at Children's Hospital here in Vancouver. Was research something that was really big for you when you were back east as well?
I dabbled in it. I have to say. I mean, my first experience in research was in first year medical school. I had spent a summer in an animal lab working with mice, and looking for genes that may be associated with alcoholism. And I knew that I was not going to pipette ever again in my life after that summer. But when I came here, I had a couple of attempts during residency, but I wasn't seriously going to do research until a couple years out in practice. And it was a bit serendipitous in the sense that I kept on trying to get admitting privileges at BC Children's as a general pediatrician. And during those days, it was a closed unit. Whoever had privileges, and there was no openings for new blood. It didn't matter that they wanted me there to admit, manage, and discharge and deal with patients who needed a Vietnamese-speaking pediatrician. Because when I came out of residency, I was the only Vietnamese-speaking pediatrician in town. So I ended up having all of them. And when they were sick, they would land up at Children, and I was the only one that could communicate with them readily. And so I'd go in and I'd look after them. And anyways, back and forth. And then eventually I asked the department head then, what will it take for me to be able to provide care for these kids under my name? Because I'd go in and I'd do it under someone else's name. Patients would be admitted by someone else, but I would be expected to actually provide the care. So I asked, what would it take? And at the time, the suggestion was, maybe you need to get some more credentials and check out this degree in Masters of Health Sciences. It's designed for clinicians, blah, blah, blah. So I got curious and I did it. I took some time off of my practice. I cut back and I did the master's. And I loved it. I love the epidemiology. I love the research methodology. And in those days, I was already doing shifts in the emergency department. I was kind of, parachuting in to cover some shifts for them as a general pediatrician. And my research project for my thesis was in the emergency department. So I had some connections with the team, and the division head then suggested that I do my project there, that maybe I would consider doing my fellowship, and then I could be hired on as their researcher. And, one thing led to another. And I ended up being a researcher in pediatric emergency medicine.
Wow. When we started this call, you received flowers from someone who you mentored, which is beautiful. Who might have been some of the mentors that really helped you in your career?
So there's a few. I think the more the merrier, and you never turn down help or guidance and wisdom. And so there's a few locally early on. Dr. Tex Kissoon, who's he's quite a fascinating character. If you ever want to talk to someone else, he was an pediatric intensivist. He was doing shifts in emergency department at the time. He's a global health researcher in the pediatric world, like the sepsis stuff. That's him. And so he really took me in and guided my work. And he's a kind of mentor that he was never too important to read what I had to write. And I still remember, like, red ink everywhere. Like he didn't just read it and say, write it again. Or he didn't just say, okay, that looks good, send it, and then crash and burn. He actually red penned everything on my manuscript. And it didn't matter what time I would send it off. I would send it off like Friday, so Saturday morning at 1 a.m. thinking, I'll have the weekend off. He'd return it the next day in the afternoon because he'd be in some other part of the world where it is daytime. And then he just took it, read it, edited it, and sent it back to me. And so that's one person I would credit. And we have, similar exotic background, let's put it that way, in terms of experience and diversity. There are a lot of infectious disease people here who I worked with early on that were helpful, that collaborated, showed me the ropes, helped me with the first few grants. Simon Dobson's one of them. Eva Thomas is another one of them. And the then division head in pediatric emergency medicine, who's a woman who inspired me to go into emergency medicine and do research and then pushed me to take the jump, but then left when I got there, is Sandy Whitehouse. She's gone on to fun other stuff that she's doing. And then nationwide, pediatric emergency medicine is a fairly recent specialty. And so in those days, you had to branch out of your province to really be connected with researchers in Peds Emerge specifically. And there's a Terry Klassen and a David Johnson, who are like the fathers of pediatric emergency research in Canada, I would say. They were very generous with their time and guidance when I started. They founded PERC, the Pediatric Emergency Research Canada Network, which is how we do research in pediatric emergency now.
What do you think is one of the most seminal papers that come out of BC Children's Hospital? This is really hard because
BC Children.
Yeah. Mm-hmm. What's something that some of our audience might have heard of or has impacted a lot of people?
I'd have to go. I think one that I think most people will know about, and again, you don't do research in isolation, right? So I think it would be the papers that we contributed to as a site investigator with the PERC network. So the one of them is an early one, is the CAN-BEST study for bronchiolitis. So looking at the use of epinephrine and high-dose steroids for bronchiolitis. So that's one of them. The other one, and now it's just on the tip of my tongue, it's a CT scan head rule, the CATCH study. And it was initiated around the same time as the PCARN head CT rule in the US. And so there was a bit of a duality for the longest time. So the CATCH rule is another big one that we contributed to. In terms of individual seminal papers, and this is totally biased. I mean, you put me on the spot here because I'm going to have to cite something that I did.
You have to, yeah. That's what I'm expecting.
So early on, so the first study I completed with this division was a randomized controlled trial of rapid viral testing. So point of care testing for viral panels in pediatric emergency medicine. And that was following a systematic review that was equivocal about the use of these rapid screening tests in kids with fever. And we completed the randomized controlled trial, and we showed that it can reduce the length of stay. No, it can reduce the length of stay, but I don't think that was a statistically significant finding. I mean, it's so long ago, but I think that we found that it reduces prescription in the family doctor's office in follow-up if we conducted the rapid screening in Emerge. So the impact was almost significant on length of stay, but what was meaningful was that knowing what the virus was affecting the child helped reduce unnecessary antibiotics.
And we all know that that has a huge impact in terms of our spectrum of
but it goes to show you how long ago this was, because back in those days, one of the emergency physicians' concern was that families came to the emergency department with fever, expecting antibiotics.
Yeah.
And so a lot of the research was conducted towards how do we reduce that? How do we steer away from that? I don't think that the same expectation is there anymore.
I would hope so.
Right, with the whole bugs don't need drugs campaign and all of that over the subsequent years, I think that there's a lot more understanding and acceptance of a viral diagnosis without having to actually confirm what virus that is, and yet still go home without antibiotics.
So you and I had spoken before, and you said that around in 2008, you had started a PhD as well. So you'd completed your master's, and then you did a PhD, and your dissertation then was around the utilization of physician assistants in the emergency room. Is that correct?
Yeah.
Lately, I heard that our ministry, the Ministry of Health, is speaking about physician assistants. I don't know if you've heard that lately. They're about bringing them in, but they don't exist really in Canada, as far as I know.
Well, in
what's your
Canada they
experience with
do, just not in BC.
Other provinces.
So there's
okay.
actually a very good program out, and I'm gonna get this wrong. I think it's Manitoba.
Okay.
And also in, I'd like to say Ontario. But this is like 2008, right? It's been 14 years. So when I started my PhD, I reached out to the ministry, I reached out to the college, and oh yeah, there's interest. It's imminent. We're gonna license them. I finished my PhD and nothing was still happening. And so it's a model that works very well in the US. I think it's also a model that in emergency medicine, physicians would be comfortable with, as in there's still some kind of oversight and ownership of the patient, although with experience and with years of practice together, PAs function, pretty much independently, and you sign charts. That's how it is in the US. And that was a model that I thought would be most easy to integrate and for physicians to accept. But as they never were licensed in BC, after I finished my PhD and demonstrated the benefits and such, there was an opportunity at BC Children's where we could have nurse practitioners. And when we started the program, the individuals that were hired in were also very open and eager to work and collaborate together. And so we had the chance to go through how they would integrate it, what would be the practice. And initially, when they started, it was very much like the PA relationship and model. And then as time went on and they grew more confident, they were more experienced. I mean, by confidence, I mean both sides, both the nurse practitioners and the physicians working together. The practice became more in line with the nurse practitioner model. But it comes from a place of familiarity, experience, built trust, and very high collegiality. When a nurse practitioner comes to me to consult on the case, it is very collaborative. It is not a case of, well, that was my patient, now I'm going to hand over to you, it's your patient. And it's I think it's more collaborative and it works well. And so we're really happy when there's a nurse practitioner on our shift.
Yeah, I think for physicians, learning to share ownership or having nurse practitioners and physicians share ownership of patient care, in many areas of our system, that's a very new thing. In primary care, we're speaking about integrating allied health and multidisciplinary teams into primary care. And the system generally has not made itself ready for that yet, just because of all of the inertia of solo practitioner work. So yeah, a lot to learn from you, and I totally agree that we have to kind of put aside our egos when we work together as a team, and work in that context of I'm helping you and you're helping me, and primarily we're aiming for a good patient experience and great patient outcomes, right? And having that really as the focus. You had mentioned that there was some type of OSCE set up that when you were starting that program, it was kind of like you had to really design a whole new training program to bring in.
We did. And so at the time, the 2 nurse practitioners that came to us, the first 2 came from different programs. They weren't in the emergency department. They weren't pediatric emergency nurse practitioner. It didn't exist. And so what we did was that a couple of dedicated PEM physicians who were really invested in this, we worked together, and we had the nurse practitioner work with us on shift, review with us in the PA model, and we focused on one condition at a time, one common condition at a time. And then after some period of time, they would undergo an OSCE to go through those conditions. And once they passed the OSCE, well, they were now expected to manage these conditions pretty much independently and not need to review with us anymore. And so we increased the bank of these conditions, if you wish. And then after some time, those nurse practitioners were basically expected to practice somewhat independently with consultation as needed. And then more came on to the program, and some of them were actually our own nurses in our ED. So there's familiarity, there's a relationship, there's experience as well. And the first few went through the OSCE with us. And then as time went by, there was enough expertise and experience in the nurse practitioners pool that they started training their own. So new nurse practitioners would come through and would train with the nurse practitioner in the model. Now, do they still conduct OSCE? I don't think so. But the materials there, the resources are there, and they have been fantastic.
Yeah, so you identified a particular need for a new type of personnel. And of course, I think the impetus for that is that we potentially can't afford to have another, full physician there. And so how do we leverage other people at the top of their scope to kind of reduce some of the inefficiencies and kind of increase the resource stewardship in the area? Is that kind of the impetus for bringing in the allied partner of a nurse practitioner?
Yeah. So then going back to my PhD dissertation, before the nurse practitioner became an opportunity and something that we could contemplate, the first few chapters of my dissertation is looking for the need. So we actually looked at what is the caseload at children's in like an example of a pediatric emergency department. What proportion of cases do we think would be amenable to be managed by a non-physician clinician? And we surveyed physicians for those. Like, what cases do you think would be appropriate, and that does not need like a 5-year residency training program to manage an emergency department? And then we also asked the patients. Another chapter was dedicated to asking what would be the family's perspective coming into BC Children's Pediatric Emergency Department and then not seeing a doctor. Would that be acceptable? And we found like reasonable acceptance of the idea and the concept. And then we looked at, well, what would be the impact on flow and operations? So I built a discrete event simulation model and we tested that. What would be the impact on flow if we added a non-physician clinician with this proportion of case in this CTAS category in this area, versus adding another full-on physician that has no discrimination in what they do? and we show the benefit, like cost for outcome. And so all of that theoretical work was done before we even had the opportunity to test out the nurse practitioner model. And once we did, I went back and validated the findings by using live data with a nurse practitioner on shift, and it confirmed the prediction from the modeling. And so there's theory behind the practical aspect. I mean, this is one of those things that we didn't just say, yeah, let's implement it. It seems to make sense.
Yeah, there's quite a bit of thought into it. It is a big investment, and if you don't analyze the risks correctly, you could be, any type of system change, we have risks for the patient. Mm-hmm. So just for the listeners, CTAS stands for the Canadian Triage and Acuity Scale. So were the nurse practitioners more CTAS 3, 4, and 5, or 4 and 5, or how did that matter at the end of the day?
Yeah, so initially it was 3, 4, 5, and then as we grew comfortable, it's now not CTAS defined but condition defined. Obviously, if there's a resus in an acute situation, a kid comes in and requires attention right away, like a CTAS 1, 2, the bedside nurse, the charge nurse will grab a physician. But after that, I mean, like for example, take croup, could be a CTAS 2, could be a 2, 3, and that would be totally appropriate to be managed by a nurse practitioner. Yeah, I don't think it is as CTAS defined anymore, and rather conditions.
Yeah, and it sounds like because now the team has been enculturated to that collaborative model, that all eyes are kind of connected to the other eyes and to the other minds, and so yeah, so it's less discriminate. Okay. You mentioned that you had to design a discrete event modeling and an ability to forecast impacts on systems, so system forecasting. What does that look like? How do you design that? Is it in a computer? Is it just math? What do you do?
So I use a platform. I use a program called Arena, but people who are savvy in programming could just design it in a computer science language like C or something like that. And the idea is, when you have a system with multiple steps to an outcome like emerge, and you got registration, triage, assign a bed, you get assessed by either a trainee or the staff, and then there's review, there's investigations, and then there's a decision, and then so where there's multiple steps, so multiple events, if you wish, in a system with competing competition for the same resources, and it's complex. It's not just linear. Like, you don't just see one person and then you go to the bank teller, you see one person and then you exit. There's multiple people that are involved at each of the steps, and some of the people are interchangeable, or the steps can use the same resources at different steps. Like the same nurse can be involved with 4 different patients, or the physician could be involved with both the initial assessment and the review and the disposition and all of that. It becomes complex. You can't just say, like a lot of studies look at nurse-initiated X-ray, say, oh, well, it shortened the length of stay for those who get that. Yes, but at what cost? Because that triage nurse is now not triaging the next patient, and the next patient's length of stay might be longer. How do you account for that? And so when it gets that complex, then I created a simulated emergency department with little dots, patients that line up and go to various places, and then use an amount of resources that takes it out of service for the other steps for that amount of time. And then you simulate, a year worth, and then you can look at all the individual simulated patients' experience and how much time they spend in which event. and then you get a sense of length of stay. And now I can change one resource at one point and see how it affects the whole system as a whole.
Wow. In my work in quality improvement, we often do process mapping. We might use some of the principles of value stream mapping to try to map out processes like that. But I've never had the chance to use a computerized simulation model. I'm curious, is that something that many, in your experience, that many different areas of our health system actually use? Do we actually use simulated models for predicting flow within our healthcare system?
Yeah. So I think the area that uses the most is probably surgery. So they can see where they put the resources. Is it room turnover? Is it booking? Is it extending the hours? To help with scheduling to reduce their wait list. And that's actually where I heard of it first, is our surgical program using discrete event simulation modeling to optimize scheduling to reduce wait lists. And operations research is the area that does this kind of work. Now, admittedly, when I started working with them, because I had to go and learn how to do this at Sawdust School of Business, and so I was in class with a bunch of, engineer students and all of that. And I felt really, really dumb, but I had to learn how to build this model with them. And then I started hanging out with the engineers that do this for a living. And what they tell me is healthcare is probably the toughest nut to crack with this technology and capacity. There is so much reluctance, and maybe there's less so now because AI has become more familiar and recognized as a tool. But back in those days, I mean, they use this in banking, they use this at the airport, they use this for traffic flow and designing traffic lights. If we added a traffic light here, how would it affect flow? Discrete event simulation modeling. If we added the hours of someone at the security at the airport, how would it affect flow? So that happens everywhere. In healthcare, a little less, we're a little like behind, and there's still some mistrust. There's still some, no, only I can come up with it. Only like, I'm special. A machine cannot predict how well I can do. And so that's a little bit tougher nut to crack, but it certainly exists. For the longest time, before the ministry shut it down, the workload model that the section of emergency medicine used to calculate and predict how many FDs we needed in an emergency department given volume, acuity, trainees, that sort of thing, used discrete event simulation modeling.
Wow. So it is being used, and I think I know what you mean. Where some people feel like, no, you can't model what happens in the craziness of my ER, because the variability of presentation is mind-boggling. So there's no way a computer can capture that in a formula or in an algorithm. I could see some of that. Yeah. I had the experience of going through some solder training for that, the leadership training that they have. And there was one of the teachers there, his name was Mahesh, and he did. Oh, do you know him? He was really into some of this modeling of different processes and flow and using computers to do it. But my project didn't have anything to do with that, so I didn't get to explore it. But it's fantastic. What was the name of the platform? You had mentioned it earlier that you actually used before.
So I used Arena.
Arena. It's just like ARENA. Okay.
Yeah, Arena discrete event simulation modeling. Yeah, and I bought a license for the duration of my PhD, and I used it. And then and they have workshops. So if you're like people who are interested in like if you're using it, you're learning it, they have their own book that is very easy to follow. And then they invite you to workshop, you go there and then you work with their engineers and with peers. And I met a bunch of people across the world using this platform, and so yeah, it's kind of cool.
Yeah, you've done so many different learning experiences in your life. It's quite amazing.
That's the distractibility of the emergency physician right there.
Yeah. Now, you've spoken to me before about developing kind of an ideal infrastructure for research in a clinical environment.
Mm.
What does that mean? Like, what has changed from when a in an environment that's not designed for research to an infrastructure in a hospital that is designed? What are some of those major components that need to be built up to
Mm.
allow for research to happen at the pace that you want it to happen at?
Mm. I think a lot of it has to do with culture. People have to believe in it and want it. The second thing is about sharing and being inclusive and being inviting. I think that the traditional, model of the physician investigator with hierarchy and nursing that is only collecting data and and just do as you're told is not conducive to successful research teams. And in a team, you have to be open to various perspectives and appreciate the learning that there is from each other. And so one of the things that has worked out great for us was when we create a pediatric emergency research council with representation from everyone who contribute to the operations and the academic life in our department. So that means scientists, that means clinicians, that means educators, that means nurse management, that means clinical nursing, nurse practitioners, pharmacy, research coordinators, and trainees are invited. And when we talk about a research project that we are going to facilitate in our emergency department, it requires all those perspectives to be shared and integrated for it to be successful. I might think that, yeah, easy, you just need to do that as a doc. But I'm not the one who's actually dealing with it when the family comes and asks the nurse. So it needs to be sensible, it needs to be well understood, and it needs to be, it needs to make sense for everybody. So I think the culture is important, and that means you need to be inclusive, and that means as investigators too, and in leadership too, right? So most of my research includes nursing as co-investigators. And when it comes to drafting the manuscript, editing it, reading it so that it makes sense to a large audience, that's what I mean by being inclusive. And then there's the resource part, right? If you have a big, happy family, then you're more likely to share your resources. And then when you share, then you're more likely to use them efficiently. In the emergency department, where patients and potential participants come 24 hours a day, 7 days a week, you don't know when they're going to come. And it's hard for a single investigator to have enough coverage to capture potential participants. But if you have shared resources, like there's 4 or 5 projects going on at the same time, then you can have a little bit from each project pitching in for coverage for that whole time. And that the individual who's on covering can now screen and recruit for more than one project. So it makes their time there more valuable as well. And so a few years back, so when this started, I'll tell you, it's funny because it started when I was building that simulation model. I needed data. Like, it's one thing to map out everything that happens. It's another thing to know how long each of these things can last. And we had it down to interruptions, like how many times per hour is a physician interrupted? And for how long? What's the distribution in minutes and the spread? And so I had students in the emergency department with a clipboard, a stopwatch, and a pen, following the doctor around and writing everything down and timing everything so that we could create, distributions and enter it into our model. And that takes a lot of bodies because we wanted different times of the day, different parts of the emergency department. And so I early on used a lot of students in my program, and I would pay them in time, teaching, mentorship, med school application review, interview coaching, you name it, right? So they come to me, they do that work, they get that experience, put it on their CV, get some reference, get some help, and then 3 months, 6 months, a year, they move, they go to med school, a new one comes on. And so that was the early model of what we have now, which is called the PEM START program. So the Pediatric Emergency Student Applied Research Training Program. And we have approximately 24, at any one point in time, 24 undergrad students from UBC mostly, who come and do 6-hour shifts in our emergency department. They get trained on the protocols for all the research projects that are recruiting actively. And during those 6 hours, they screen for those studies. They approach, they get informed consent, recruit, collect data, and then project completes, done. We get a new project, we retrain everyone on the new protocol, and there's a flow of students that come through. And so at 12 hours a day, 7 days a week, we have a research assistant in the emergency department. How do we pay them? Coaching, mentoring, teaching, reference. Sometimes we have to have some paid RAs or coordinators to fill some holes. But because we have the infrastructure, investigators can actually get grants to do the research, and they don't have to cover 7 days a week, 12 hours a day. They cover those holes, and then it works.
Wow, so much of the infrastructure that you created, it does depend on volunteerism. It depends on these undergrad students, and they get some quid pro quo by spending their time and being kind of your censors for for research candidates. Very interesting.
Mm-hmm. And it's a model that is across Canada, right? So they have that in Alberta, at Sick Kids, at CHEO in Ottawa. So for the emergency department, that's the need, because, well, 24/7, how do you staff that, right?
Yeah. Now, if somebody wanted to become part of that PEM START group, if there's a student listening now, how do they join up?
So I think that if you just Google PEM START, it will bring you up. But otherwise, the bcchr.ca website has the profiles for all the investigators at BC Children's. And under my profile, there is a link to PEM START with the descriptions, the eligibility, the criteria, the contact for the coordinator. And now it's a program that runs itself. And the emergency department, the division, funds the coordinator to do all the scheduling, the training, and we provide mentorship. There's like every 6 weeks, there's a meeting for all the starters where we go over research designs, and it's a bit of a hands-on workshop where they learn how to design a certain type of study. There's prizes, there's like bragging rights, there's a bit of a competition going on.
You had also mentioned that something called research efficiency design, or does that include exactly what we talked about, like kind of making research more efficient, or does that ring a bell?
Mm, I'm not sure exactly what we're referring to. I mean,
Okay.
my area of research is health services research. So
Mm.
I look at efficiency, value,
Ah,
I look at
yes.
cost, I look at operations changes. So that discrete event simulation modeling is one of a project within that program.
Mhm. When you compared the modeling to what real world was able to produce, how close was the modeling to what was produced? Did you ever get a chance to do a retrospective around that?
So yeah, so after the model was done and published, we started the nurse practitioner program. And so sometime after that program was running, in fact, a nurse practitioner and a nurse in the, I would say, MHA program worked together with me to collect the data retrospectively with shifts with nurse practitioners on and shifts without. And then they run the analyses and found very similar impact as what the modeling predicted.
Ah, okay. So it did match up. So the
Yeah, that's what I meant by we ended up, after the model was published, we validated the model with real life data.
I see. That's fantastic. Now you became the director of clinical research at Children's in 2020. Is that right?
Yes.
And then and then in late November of 2021, you became the director of a research institute. Is that right?
Yeah, so in late 2021, I became the interim senior executive director.
Ah,
And I've been in that role since, yeah, end of November, early December.
mm,
And we're just restarted the search process for the permanent senior executive director.
mm. And you had mentioned that there was a lot of learning in the admin side of things. What did you mean about that? What is what, for people who are aspiring to do more administration in the health sciences? What are some common challenges they might experience?
Well, there's challenges, but there's also great opportunity. I will have to say, often as physician, especially in emergency medicine, we kind of learn to do everything ourselves, right? That's the fastest way. There's no nurse around, I'm gonna go get that popsicle.
I'll
Do you
just
know
do it
what I mean?
myself,
Or I'm gonna
get
go
it
get
right.
that reflex hammer. So
Hmm.
we learn to do everything ourselves. And that's often how we approach a research project. That's how we approach a QI project. And then when I started working as and more so as as the interim senior executive director position than in clinical research because it's much bigger, then you realize that in those roles you're so well surrounded. There's such a big team of really competent expert people helping you run the big business. And so you don't have to do everything yourself. In fact, most of the things that you think you should be doing can be done so much better by someone else. Not because it's not worth your time, but because you're just not trained, nor do you have the experience to do it effectively. And so I'm working with a lot of, program managers, program directors, and you just realize how much more collaborative that area of work is than when you're, you know, working in as an emergency physician trying to get things done, right? Like you're doing your own booking with me, right? We're sending each other emails and doing scheduling. And you get to a certain level and it's like that's not feasible anymore. And there's like 3 people playing with my calendars now.
So you're learning about delegation and about
A
working at the top
lot.
of scope. Okay.
Yes, a lot. But then you also realize how certain decisions get made. And it was an eye opener as well, about and the range and the scope of decision making. It's fascinating. You're dealing with big bucks, And that's probably the thing that I think that maybe culturally I've always been raised to be very frugal, and one of the issue I tend to have, which I don't know that I should say this out loud, but it's like my projects end up like I don't have a budget issue, like because I'm so frugal. I find ways to do things on the cheap, and so I managed to get a lot squeezed out. And then you go into a leadership position where, you know, you're dealing with big numbers, and it took a bit of time for me to get comfortable with that.
You had to shift your perspective on the monetary
The
paradigms
scope,
that,
my gosh,
yeah.
it's so much bigger, right?
Hmm. Well, I think it's so important that someone with your perspective is in some of these leadership positions to influence a good resource stewardship. So thank you for that. You know, I come from a coupon clipping family, and I appreciate you.
Yeah, and it's not to say that there's waste or anything. It's just that it took me some time to get used to making these big decisions that with those big numbers, and it takes some getting used to.
Hmm. What do you see as some of the biggest opportunities within your area of the health system? What are you really excited about that you feel that not enough people are aware of, that people are not capitalizing on a particular opportunity?
Hmm. I think one thing that I've been dropping hints about at every opportunity is to involve the stakeholders in our problem solving exercise. And by stakeholders, I don't just mean decision makers and politicians and government. I mean healthcare users. At the end of the day, they pay for it. I mean, we can say that it's free, but it's not really free, right? We pay for it through our taxes. And whether we want more of it, we want a different kind of it, we need to engage healthcare users better. Often I find that we try to solve problems like emergency department crowding and such between ourselves, right? Or between ourselves and government. And we don't engage users enough. And I wonder if the big divide that we're facing right now with the pandemic, and how much there seems to be a dichotomy or mistrust with and misinformation between public health offices and the population, is because of not enough transparency and engagement in some of these decisions. I'm not saying let them decide, but if you don't engage them, then what ends up happening is that they act like they should decide on their own too, and hence all the protests and all that, right? And so I think that when it comes to making alterations or problem solving, when it comes to utilization, when it comes to, you know, wait time, when it comes to crowding and surges, we need to engage them in the problem solving part of it. And that's what I'm trying to do when it comes to health services research. So one of the major steps before we went and said, oh yes, let's license physician assistants or let's bring nurse practitioners, we asked patients, right? We can't just say, oh yeah, nurse practitioners or physician assistant will save time, save money, improve efficiency, let's just bring them on. And what if the patient says, no, I don't want to see them? Or they make a fuss, and then the nurse practitioner, the physician assistant has to call in the attending, and then there's a lot of conflict resolution. It doesn't help anything. And so you need to engage them in this, in the process of finding solutions. It has to be a solution that is palatable to the users. But also when they get informed and they understand the scope of the problem and the choices that we have to make, they may accept the solution better as well.
I totally agree. I think that we underutilize that resource of speaking to patients, the users of our system, who are funding our system. Every taxpayer is. So thank you for that. I totally agree. You had mentioned that some of the work that you've done has potentially been disruptive of the traditional hierarchical structure of how research has been done. What do you think are some of the detriments of that, the old way of doing things in terms of research? How does that impact the knowledge base maybe that we gain? If it sounds like you've almost democratized how research is done, and you've built a more inclusive team that captures a lot more data in its current form. You and your teams have. Can you speak to some of that, the impact there and the benefits?
I think it's very similar to the whole discussion about integrating equity, diversity, and inclusion principle to our work in general. I don't think it should be just research, but I think that the more inclusive and the more diversity of experience we bring on and we open ourselves to, the more creative we become in our approach to things, and the more effective we can be. I think that we may think ourselves in silos, but in fact, no one single intervention in healthcare is driven by only one group of individuals or types. So in a trial, you may think that, and again, that's not even true. You don't need to be a physician to be a scientist and a trialist. If it comes down to methodology, it comes down to experience, expertise, and rigor in your work, you don't need to be a physician. So if you take away the titles and you just include people with the right experience, the right expertise to do the work, then the work will be done better than to hang on to traditional, oh, you got to be a doctor to do this. Secondly, I think that when you report your findings and you share the knowledge, you want an audience that is wide, to be able to uptake the information that you're sharing. And so the wider the base in creating the knowledge, the more accessible the knowledge that you disseminate will be.
Yes, and it sounds like you've created a lot of the fertile ground for that type of knowledge sharing.
And I'll tell you one more thing. Doctors don't like this now, but I also think that it also dilutes some of certain behaviors. Like some egos and such. The more diverse the team in terms of multidisciplinary background, the better people behave.
Yeah,
and
in community,
for,
we moderate each other in community.
Yeah, absolutely. And it makes for a more pleasant workspace.
Yes. Wow. As a person of color, coming up in healthcare and healthcare leadership, and in the foundational generation of new knowledge for our communities in health sciences, what have been some of your takeaways about how a woman of color can succeed in the system?
Yeah, I think there's still a long ways to go. I think that as challenging as it has been, I have also benefited from some privilege. White proximity, being considered a model minority has allowed me to get advancement in a way that I think is not still available to all people of color. I think there's still a lot of understanding to be had. I think that a lot of very well-intended individuals are still perpetrating systemic and structural challenges for people of minority groups. And there are things that we don't always think about, right? So most recently, even, and I'm still learning, we're talking about scholarship and for grad students. And I was taking the perspective of, well, if the scholarship goes toward the base stipend that a supervisor is meant to find, because as you know, as UBC, to even take on a grad student, you have to guarantee a base stipend for them for the duration of their studies, which is roughly 25,000 a year. It's not much to live on in Vancouver, but that's the minimum. And if I want to take on a PhD, I have to guarantee that base stipend for my PhD student for their 4 to 5 years program. And if a scholarship goes towards that 25,000, then the student still only takes home 25,000. It didn't benefit the student. It benefits me as a supervisor, right? So then it's almost like a bribe for me to take on a student of color, because it's going to cost me less to have them in my lab. It's paid for by the scholarship. So the student doesn't benefit from it. So that was my perspective. And then someone else brought the perspective of access. Well, what if I only have 25,000 and there's 2 competing students? And this is what was expressed to me. What if they're not equally well performing? Having a scholarship would allow me to take them both in and provide access to a student that is from a minority group. And my argument was, well, why do you presume that the student from the minority group is not performing better than say your typical privileged student? And why would they need for me to have extra money to take them on? Why wouldn't I just take them on as opposed to the other student? And then it was explained to me that when you have to take on jobs to make through your undergrad studies, if you have to support your family financially, you will be dinged on things like grades, like experience, volunteerism, extracurricular. And so the criteria by which we judge people, the traditional criteria, are still very how can I say? Yes, but they also disadvantage people who already are disadvantaged. And so even if they are smarter, harder working, have more potential, on paper, they won't look as good as a privileged student. And they will still lose out when it comes to the one position I have in my lab.
Wow.
And so to me, the solution is, let's change those criteria. I saw something recently in a tweet about med school evaluator that says volunteer experience is huge on their list when they choose candidates. And again, who has the privilege to be able to volunteer?
Yeah, someone who's already financially stable otherwise, someone with some disposable income, someone
Whose
with
parents
connections.
are, yes, connections, families well off, you know, they don't have to feed their family. And so that perpetuates the inequities.
Wow. Yeah.
So there's still lots we need to do systematically. I'll tell you another one that gets me is when it comes to cultural background and the way we portray ourselves. And for sure, gender has a role in how one self-promotes. And it's something that many of us have to learn to do, and it still feels icky, right?
Yeah.
I've had to learn to do this, otherwise you wouldn't get anywhere. And so, I've had to write my own letter of support, tuting myself, right?
Yeah.
And it's very icky. It feels very unnatural. And there's evidence out there that some gender are more comfortable doing that, right? And it's not equivalent across the board. And so as long as the system promotes that sort of behavior, then you will have groups that will be perpetually, suppressed.
Yes. Yeah. There's still a lot of work to do in creating a more equitable society. Yeah.
Mm-hmm. I recently got an email, a well-intended email to a group of 5, 6 female physicians about great resources about EDI and racism and gender inequities and such. And I fully appreciate the intention. But why were those resources sent to 6 female emergency physicians? If those resources are good, they should be shared with the whole department, particularly males.
Yes, because males ought to be able to share them on and learn from
They would
those,
probably benefit from it more so than the people who are experiencing it.
because they're education focused. Yeah.
Yeah.
Mindset widening, mindset
Right?
expanding.
Yeah. So to me, see, we're still not thinking about, who needs to learn about this, right?
Preaching to the choir.
I know. And so there's still some things that are, I think, intentions are great. There's a lot of good intentions. I think we need to focus on impact. What are you trying to accomplish? And is this going to reach that impact?
In our quality improvement work, we use the model for improvement, and it's, what are you trying to accomplish? What changes might you make that might get you there, and how do we know that it actually works? Those 3 questions combined with the PDSA cycles.
And who do you target to achieve that impact, right? If you want to change the system, you want things to be better for women, do you send it to women?
If it's a mindset widening, you got to send it to everybody. Yeah,
that's right. You have to send it to everyone.
Well, Quynh, I really enjoyed our talk today. Is there anything else you'd like to add before we sign off?
There's one aspect that we haven't touched on that I think is really important coming up.
Yes.
Is the mental health of kids and young adults, especially with what's going on in the world right now. And it's not just the pandemic, it's all the catastrophes. And I think it's something that is worth thinking about. Screening and accessing resources early. So that's my message. And that has been the focus of my research in recent years, is creating, validating, and evaluating, implementing tools for people to self-check, or at least the kids. And now we're working on a young adult version for post-secondary school students.
So how, if I as a family doctor want to have empower my families to check their children, or for the children to check themselves, where do I send them?
So the easy bit is trek.ca, TREKK.ca. That's the knowledge mobilization platform that pediatric emergency physicians have created and are maintaining. And on there are resources for families. Actually, there's a lot of resources for families. not just mental health, but like how to manage croup, gastro, when to come to the emergency department for each of these things. And the infographics and information for, there go, My Heart's Map. Oops. Oh, you can go there too, and you can go down to My Heart's Map, which is the one that I'm referring to on the right.
Oh,
one of the gray tab. Yeah.
Oh, that's one.
And so there are infographics, there are videos, and then you can access the tool, which is the screener.
There's a video that they can watch, and then they can start, and it'll have some questions for them to fill out.
Yeah. And then at the end of their assessment, we use an algorithm based on their scoring and the pattern of their scoring to trigger recommendations and a list of resources where they can get the help that they need for what they've reported.
Wow, that's fantastic. And it's sad that I don't know about it. I'm going to tell everybody. That's awesome. Well, thank you. Yeah, it's the pandemic has been really challenging. I do have two young children, and yeah, they've had, unfortunately, a lot more screen time and much less, social time in these past 2.5 years. And yeah.
That in itself is not necessarily bad. I think the issue is that they've also been exposed to a lot of badness in the world that they may have access or been exposed to through screen, but it's how to help them process all of that information and how to cope with those fears and anxieties. That's important to address.
I think that they have empathically sensed the distress of a lot of the adults around them, and the adults who have not fully processed the actual safety of their immediate environment, but have actually taken into their psyche the angst and fear and uncertainty around them, and unwittingly transferred that into our children. Yeah.
Absolutely.
Yeah. I know that at Children's there's the gentleman Zung Vo, who wrote some of the books around anxiety for children and mindfulness for teens and children. Yeah. You work in a very prolific environment, and I think that's fantastic.
Yeah, great colleagues to share with.
Anything else you'd like to add for today?
I think that's it.
I want to thank you again for taking this chance. I know that we don't know each other prior to this talk, and I'm so grateful for your time and sharing. And I think a lot of the stuff that we discussed today is going to be helpful and inspiring, I think, for a lot of our listeners. I'll make sure I send you a link after so you can share it with your friends too.
Thank you.
Thank you so much. Gamen.
Thank you. Bye.
Bye.